department. She's a very eminent professor. طبعا هي غنية عن التعريف وهي يعني very dedicated و honest والحقيقة بتقعد في القصر لغاية الساعة 7 يعني. فالدكتورة إيمان يعني ليها بصمات في البون مارو يونت جامدة وهتقدم لنا interesting case إن شاء الله. اتفضلي.
يعني بشكر طبعا ان انا ادوني فرصه اني اقول في المؤتمر ده مؤتمر الاسم بتاعي. هو كده صوت كويس؟ يمكن بقالي مده ما قلتش في مؤتمر الاسم بس بحب اقول فيه دايما يعني لما بتشجع كده. فالكيس اللي هنتكلم عنها النهارده it's a curious case of sarcoidosis beyond the granuloma. So our case was a female patient, 36 years old, that has been diagnosed with sarcoidosis since 2018 and received immunosuppressive therapy for 2 years following initial diagnosis. Today she was presenting to us in 213 with exertional dyspnea, anemic manifestations, headache, throbbing pain, and blurring of vision. Clinical examination revealed hepatosplenomegaly, and ultrasound revealed a spleen of 16, confirming the clinical hepatosplenomegaly, and a liver of 16 centimeters. High-resolution computerized tomography revealed multiple scattered pulmonary nodules. Largest was 7 millimeters in diameter, with paratracheal, hilar, and aortopulmonary lymph nodes, which was consistent with the previous diagnosis of sarcoidosis. Further laboratory investigations. Number one, we had to do a CBC. Patient showed macrocytic anemia and thrombocytosis. The anemia was non-regenerative as the reticulocytic count was 2.5%. ESR was elevated. So are these common findings in sarcoidosis? The hematological anemia and hematological anemia disorders in sarcoidosis include anemia, which is mainly microcytic hypochromic, or either autoimmune hemolytic anemia or hypersplenism. And in all cases, it's not a macrocytic anemia. The commonest is thrombocytopenia rather than thrombocytosis, although any inflammatory condition could present with thrombocytosis. Yet our patient presented with a thrombocytosis with macrocytic anemia, so B12 could not be implicated in the cause of the macrocytosis, neither does the reticulocytic count. An examination of the bone marrow aspirate and touch print revealed a depressed erythroid series with myeloid hyperplasia, a blast cell count of 4%, megakaryocytic hyperplasia with presence of hypolobated and monolobated megakaryocytes together with abundant bone marrow platelets. And that's a photograph of the touch print, and that was the aspirate first, and that's the touch print revealing the monolobated megakaryocytes. With an occasional blast. Bone marrow biopsy sections revealed a hypercellular bone marrow. Cellularity was approximately 90%, with presence of multinucleated giant cells, collections of multinucleated giant cells, and interstitially scattered multinucleated giant cells. Together with the classic picture of sarcoidosis in which there are minimal lymphocyte infiltrate in between the giant cells and with a cuff of eosinophils around them. A classical asteroid body was seen in one of the multinucleated giant cells, pointed to by the arrow. Myeloid was mainly predominant, and the mononuclear megakaryocytes were more evident and increased in the biopsy. Trabecular bone was largely normal, and this was the only trabecular bone presenting with an occasional erosion and osteoclastic activity. The reticulum was normal with exaggeration within the granulomas. The typical immunophenotype of the lymphoid infiltrate of the granuloma consists of CD3 positive interstitially and around the granuloma and a little of the CD20B positive cells. CD34 was done to confirm the increased blast or to see any presence of any abnormal distribution for the CD34. However, it was only interstitially scattered and did not increase than the 5% of the aspirate smears. As we revealed that we could not detect any evident erythroid islands on examining the biopsy or the touch print, CD71 was performed, and it revealed a decreased number of erythroid islands, disruption of the normal erythroid islands, together with variable size, as occasional large erythroid islands were seen, as demonstrated in the picture on the left. So we have a case diagnosed with sarcoidosis together with presence of myelodysplasia and myeloproliferation. So our differential diagnosis, we have a case of macrocytic anemia with monolobated megakaryocytes, abnormal erythroid islands, thrombocytosis, and 5% CD34 positive cells. Our first diagnosis based morphologically was MDS with a low blast cell count and isolated 5q deletion. However, a myelodysplastic myeloproliferative neoplasm with SF34B1 mutation had to be excluded. So what is the association between sarcoidosis and hematological malignancies? Is there an association? Well, it has been mentioned at a question in another paper, and they found that mainly it's a lymphomatous or non-Hodgkin lymphoma. However, some papers revealed an AML and a CML and an acute promyelocytic leukemia and MDS with excess blasts to either precede or follow a diagnosis of sarcoidosis. Two case reports on reviewing the literature. We had a case with sarcoidosis with myelodysplastic syndrome in an elderly woman, and another case of myelodysplastic syndrome preceding myelodysplastic syndrome presenting as sarcoidosis. But in both cases, the MDS preceded the diagnosis of sarcoidosis. In another case report, a coexistence of sarcoidosis and myeloproliferative disease, still sarcoidosis appears to be an underlying cause to subsequent malignancies. What is the connection between MDS and sarcoidosis? The only connection that we could think of is the microenvironment. They both have an inflammatory microenvironment. A pro-inflammatory type 1 is implicated in the pathogenesis of MDS, together with the increased responsiveness of the MDS hematopoietic stem cell to apoptotic signals. Also, sarcoidosis, it's an inflammatory condition that may be triggered by an antigen, leading to granuloma formation and accumulation of CD4 positive cells with a cytokine production also. So we recommended further investigations. We had to do an iron staining to exclude the ring sideroblasts. However, our touch print and the aspirate did not have enough erythroid to diagnose anything from them. So we had to do the mutational status of MDS, the 5q, the 7q, or monosomy, as based on morphology. With our first diagnosis was an MDS 5q syndrome. So we have to exclude a monosomy 7, as monosomy 7 could not be present with a 5q syndrome. Second, we had to do the TP53 mutation for two reasons, because MDS with a biallelic TP53 inactivation supersedes the diagnosis of 5q negative syndrome. And the second thing, that the TP53 mutations consequently contributes to treatment failure and disease progression in low-risk MDS with a deletion 5q. Also, due to presence of thrombocytosis, myeloproliferative mutation analysis was performed. Why do we do a JAK2 mutation? Although it's rare in all types of MDS, yet it occurs at a higher frequency in the 5q syndrome. This was the FISH analysis for the 5q, revealing loss of one of the 5q minus, or 5q minus positive, and the other one for the 7q, it revealed a normal 4-signal FISH. So we have the case of a 5q deletion positive, 7 deletion negative. Okay. The BCR-ABL and the JAK2 were negative. So what mutations in TP3, changes in expression, leading to gain of function, either loss of function or the loss of the gene altogether. The mutational status of the TP53, although it's much more reliable technique as a FISH and the sequencing, yet immunohistochemistry techniques are simpler, inexpensive, and faster, and are considered a surrogate marker for the TP53 alterations, including mutations and deletions. So we did a dual staining for P53 and CD71. As we could not assess, we have to exclude the lymphoid portion in order to account for the PT53 only in the hematopoietic elements. The green signal is for the P53, while the 71 is colored in brown in immunohistochemistry. We had a grading system according to which the medium staining, strong staining, and weak staining. So result interpretation, percent of positive cells were found to be 3.6%, normal is less or equal to 10%, percent of P53 strongly stained cells is 0.5%, increased expression is considered when there's more or equal to 1% strongly stained cells, so this patient had a normal expression for the P53. We recommended further investigations for the mutational status of the TP53, nucleotide sequencing, and FISH. So our case was sarcoidosis with MDS 5q syndrome, and the patient is being prepared for bone marrow transplantation. These are my references, and the cooperation between our lab and the cytogenetic lab to diagnose this case. So I thank all my colleagues that contributed to this case. Thank you.
Thank you so much, Professor Dr. Iman Mansour, for this interesting case. الحقيقة في البداية أحب أقول إنه يسعدني ويشرفني وجودي مع حضراتكم النهاردة في المؤتمر السنوي لقسم Clinical Pathology كايرو يونيفرسيتي. وبحب أشكر أستاذة الدكتورة نسرين الغرباوي أستاذ Clinical Pathology كايرو يونيفرسيتي ورئيس القسم. بشكر أستاذة الدكتورة رانيا زايد أستاذة كلينيكال اند كيميكال باثولوجي كاري يونيفرسيتي وسكرتيرة المؤتمر على دعوتهم الكريمة. والحقيقة أنا ببقى سعيدة كل سنة بحضوري ويعني حريصة على وجودي معاكم في المؤتمر. حقيقي محاضرات قيمة و يعني very interesting topics as usual. وببقى سعيدة جدا بمقابلة زمايلي وصحابي من القصر العيني ومن الجامعات الأخرى. فبجد it is such a great scientific and social event. Thank you for giving me this opportunity. Thank you for organizing such a successful and productive conference. Thank you. Now I would like to introduce the second speaker, Dr. Amira Abbas, lecturer of Clinical and Chemical Pathology, Cairo University. She will talk about the brain abscess in immunocompetent adult patient.